So the next topic, medial tibial stress syndrome, or shin splints. This is something that's extremely common. In fact, 1/3 of our athletes and soldiers suffer from shin splints at some point in their career. 15% of all running injuries are related to this condition. So medial tibial stress syndrome is often thought of as growing pains, but the recent study told us growing pains may not actually even be a diagnosis, that this study told us that there's no association between the maturation of a young person and growth in musculoskeletal conditions. So that's not the process. A lot of times these patients are just suffering from injuries to different tissues. As our growth plates change, we're going to see different rates of stress. So in the medial elbow, in a little league elbow, we're going to be pulling on the growth plate. Once that growth plate fuses, we're going to be pulling on the medial epicondyle, so it'll turn into medial epicondylopathy. And once it's been fused and hard for a long period of time, we're going to be pulling on the ulnar collateral ligament, and then we turn into a Tommy John surgery. So growing pains, just because you're growing, that's not the case. It's because there's abnormal stress. So our goal for someone with shin splints is not to tell them to wait until you're done growing. It's to actively address the stressors that we can. And that stressors typically affect the bone. So there's a bony stress reaction to this, a periosteal inflammation, and a myofascial strain. We see this as a continuum, that while it starts as a myofascial strain, eventually that myofascial strain starts to irritate the periosteum. And as that continues on, now we have a full bony stress reaction that will eventually soften the bone and allow us to develop a stress fracture. As we'll see in this presentation, that shin splints is a continuum that ends in stress fracture of the tibia. So the two muscles that we're most concerned about are the tibialis posterior and the flexor digitorum longus. Both of those insert onto the medial border of the tibia. And when they're chronically pulling on the area, especially when that tibia is under some degree of torque. And how does that tibia get under torque? Well, yes, you guessed it. When the hip abductors are weak or there's hyperpronation, the knees dive inward, which forces internal rotation of the femur and tibia, which creates torque. So that's the generating force. It's not simply overuse of that muscle with good mechanics. In the majority of cases, there's an underlying functional deficit that allowed that to happen and to progress. One of the factors that compounds that is certainly activity. That this time of year into the fall is when we see a lot of these injuries starting to ramp up because our athletes are transitioning from outdoor sports of softball and baseball into indoor sports of volleyball and basketball. And so as those sports starts to ramp up and people are putting on more mileage as the weather turns nicer, those hard surfaces and constant pounding with eccentric contractions of those two muscle groups is what tends to cause the problem. And they broke the terrible twos rule. Too much, too fast, and too long. And anybody knows that the terrible twos can be a painful process. There are factors that make an increased risk of this. So increased risk are going to be if the patient hyperpronates for the reasons that we've talked about and the reasons that we'll make even more clear toward the end of the presentation. If the patient has had a prior history of shin splints, we're going to see a greater likelihood that that's going to happen again in the future. And if they have too many pounds, that's no surprise that we're putting more stress on that tibia. Once again, as I've alluded to so many times throughout the presentation, unfortunately, females have a higher incidence of these lower chain problems, including medial tibial stress syndrome, where the risk increases 1.5 to 3.5 times risk of progressing toward a stress fracture. So our patients with shin splints will often complain of pain after they've been running or jumping. So it's not necessarily during, at least in the initial stages, it's after that activity. And it's vague and diffuse, usually a long area of tenderness along the medial border of the tibia. And as that progresses, those symptoms then can start to linger. They can go longer into the afternoon or evening, and they can also come on earlier in the workout. The other thing that they tend to do is shrink in area. So as they shrink in area, that's a little bit of a concern. That usually we're going to feel maybe a bumpy area on the medial tibial border. I'm sure you've felt that in some adolescent athletes. And it's generally 5 centimeters plus. As that shrinks, that's not a good sign. Because what's happening, let's imagine I have a piece of paper with a small tear in it. If there's not a tear, first of all, and I just put stress on the edge of that paper, we're going to see all of those pain sensors along the top edge of that paper are going to yell equally. But as we start to develop an area of stress, now when we stress it, those are the only pain sensors that are going to scream. So as we transition from shin splints into a patient who now has a tibial stress fracture, the area is going to shrink, but it's also going to increase in the intensity, and it's going to increase in when it happens. It's going to start happening throughout activity. So pain that persists more than 5 minutes after activity, we have to be suspicious of a stress fracture. And pain that has shrunk down to a very small area, we have to be very suspicious of a stress fracture. The way that this progresses is we start here with a normal bone. The normal bone then advances into having a grade 1 reaction, which means there's a little bit of a periosteal inflammation, which then changes into a little bit of a marrow edema as well, which then starts to soften the tissue in between, and we get some cortical irritation, and eventually we get a little line that starts to show up into a stress fracture. So this benign, soft-sounding process of shin splints is not benign. It's a precursor to a stress fracture in every incidence unless something intervenes. And that's not simply a matter of time. It's a matter of changing the mechanics that allowed this to get stressed in the first place. Here's a slide about the differentiation of shin splints versus stress fractures. That shin splints are typically diffuse. It hurts when you start activity, and it's most tender over the flexor digitorum longus and tibialis posterior. Whereas a stress fracture is focal, the pain persists more than 5 minutes. There's oftentimes swelling. If you put your vibrating 512 megahertz tuning fork over the area, 75% of the time, that's going to light up and be uncomfortable in a stress fracture. And single leg hopping, having that patient hop on one leg, is 70 to 100% sensitive for a stress fracture. The other test that can be helpful is the Taylor bump test, which is simply having that supine patient with their leg extended bump on their heel. And if they say, ouch, well then that's probably more than just irritated muscles, because irritated muscles probably wouldn't hurt when you give the talus a quick, abrupt bump. One of the clinical red flags that we want to be alert for that can often happen in our young athletes is a compartment syndrome. So a compartment syndrome means that one of the 3 compartments of the lower leg has developed swelling to the point that we've now compressed the venous exit of blood, which means the arteries are still pumping blood in, especially during exercise, but there's so much pressure the blood can't get back out, so it's filling up like a balloon, which means that eventually that balloon is going to start choking things that live in the area, like the nerves and the muscles. So there's going to be pain associated with that, but also numbness or paresthesia. Our patients who have shin splints with numbness or paresthesia don't have shin splints. These patients have at least a coexistent compartment syndrome going on. So how are we going to assess this? Number one, you guessed it, we're going to look what are the underlying biomechanical stressors. We're going to have that patient perform a single leg squat. We're also going to have them perform a single leg hop test, which is pretty simple. The patient's going to stand and they're going to hop on one leg. Now this patient's a little non-compliant. They're not listening to what they're supposed to do, but you can imagine what a single leg hop looks like, standing on one leg and hopping. And then we'll do the talar bump test, either with the leg supine or in this case, bringing that knee up to 90 degrees and giving an abrupt bump to the talus. And if we give that bump to the bottom of the calcaneus and talus and the patient reports pain in that focal area, that's a concern. We're also going to use imaging in appropriate cases. So when that pain starts to shrink, then we're going to take a picture. Now, a patient with simple medial tibial stress syndrome probably doesn't need a picture taken. But when we start to suspect that there's the possibility of a fracture, a stress fracture developing, then we're going to image it, especially if there are red flags of focal tenderness, pain at rest, and they don't improve after a short period of care. The things that we're looking for are those little lines. So when we start to see periosteal elevation in the midshaft of the tibia and then a potential fracture line in the middle, that's what we're concerned about. What do we do in office? Well, first of all, we're going to work out the muscles that have become tight. One of those muscles that's often tight is this, the posterior tibialis. That posterior tibialis runs off of the tibia along the medial border of the medial the backside of the ankle and then onto the foot. And as it runs around that medial malleolus, a lot of times it will become irritated in a posterior tibial tendinopathy. but it's also being chronically stretched, especially in a patient who has fallen arches or hyperpronation. And that chronic stretch and hyperpronation, which are very crucial to the development of medial tibial stress syndrome, also cause irritation of the muscle. So we're going to work out the trigger points within that muscle. We'll work out the trigger points within the tibialis anterior muscle, that this is another muscle that frequently develops tenderness and trigger points, especially more up proximally in the end closer to the knee. So we can work those trigger points, strip the muscle out, and certainly working out the gastroc and soleus, that the gastroc and soleus are plantar flexors of the foot, and a lot of times with most any knee or ankle pathology, the gastroc and soleus become tight. So we can do a myofascial stripping, as you're seeing Dr. Steele do, or a pin and stretch, where we shorten the muscle, drop it down as we take that patient's ankle into plantar flexion and strip over the top of that trigger point. Again, same principle, shorten the muscle, trap the trigger point, lengthen the muscle as we strip our thumb over the top of that trigger point, which in this case of the gastroc and soleus are oftentimes proximal trigger points. The other thing that we'll do is to make sure that that patient knows how to keep those muscles limber themselves. So we'll teach them the Gastroc Stretch. So this is stretching her right gastroc with one leg back, leaning into the wall. Again, a contract relax version is to push into the floor, relax and stretch further forward. Push into the floor, relax and stretch further forward. Now let's not forget that the gastroc and soleus can generally not be stretched with the same movement. A lot of times one will be tighter than the other, and so we'll get a lot of stretch in one but without stretch in the other. The other thing is that the soleus, in order to stretch it, we have to loosen up the gastroc a little. So the way we can loosen the gastroc is to bend the knee. Since the soleus doesn't cross the knee, we can get a stretch in the soleus after we bend the knee. So to stretch the soleus, we have the patient with a knee bent and their foot up on a curb or a ball or a box of a couple of blocks or a book, anything to elevate the foot into a little bit of dorsiflexion, and then we're going to stretch out that posterior chain in the same way. It can be either a static stretch or it can be a contract, relax, and stretch. Contract, relax, and stretch. A dynamic gastroc stretch is helpful because this is something that can produce some strengthening of muscles that are crucial as well. And the dynamic gastroc stretch simply works by having that patient stand on a chair or a box and drop their heel down. And then they can come back up and drop their heel back down to get a good stretch. This is a great stretch to do in a stairwell, especially if it has a couple of hand railings, that they can get a good stretch in that area just so that they're not bouncing too much at the end. We don't want necessarily that type of a dynamic stretch, just a slow static stretch to allow that to come down a little further each time. And like almost all stretches, we can convert this to a contract relax where she pushes and stretches, pushes and stretches. The other thing that we'll want to do is to strengthen the arch of the foot. That, as we'll see in the next section, hyperpronation is a contributing factor to so many of these problems, and the way that we address hyperpronation is not by simply dropping them into an orthotic, but hopefully teaching them how to actively strengthen the area so that they don't have to wear an orthotic the rest of their life. And a great posterior tibialis strengthening exercise is this: wrapping a piece of elastic band around both feet and then having that patient rock their foot up as though they're trying to look at the bottom of their foot. Relax and take it back down. Look at the bottom of their foot. Relax and take it back down. So that's strengthening that posterior tibialis, which is that band of duct tape that comes off of the bottom of the foot, up the side of the shin, behind the medial malleolus, and onto the tibia, and it helps to support the arch of the foot. And yes, this muscle can be rehabbed to the point that it can help support the arch. If somebody has pes planus, maybe not. But if somebody has hyperpronation, where their arch is dropping away when they're walking and running, yes, it's very likely that we'll be able to strengthen that muscle for them. We'll also look at the other end of the chain. You knew that this was coming. We're going to have them do things to strengthen the hip abductors and to strengthen their core. This is a great exercise, a semi-stiff deadlift. And the way a semi-stiff deadlift works is the patient is going to stand up straight and they're going to take one leg back as they bend forward at the hip and then come forward again. So they're bending solely at the hip. There's no lower back bend in this process. They're imagining that they have steel rods in their abdomen and they're bending forward and coming back up again. That's a great exercise in order to help strengthen some of the core and the hip musculature. Now, can this patient go back to running once that they've had shin splints? Well, yes. They can go back to a level of activity, whether it be volleyball or basketball or running, but we want to gradually ramp them back up, because what happens in shin splints or any stress fracture is the rate of bone destruction has exceeded the rate of bone's ability to repair itself. So resorption has outpaced the ability to rebuild. So we just want to make sure that we don't outpace it again on the way back up. Once that bone has started to heal, we'll gradually ramp up the activity by no more than 10% per week. Again, the 10% rule that I love to teach patients. If you escalate your activity by more than 10% per week, you're probably going to develop some sort of a process. You'll figure out which glass is about ready to overflow. We want to, in this case, increase distance before pace. So faster running is going to put more stress on those muscles, more pronounced exacerbation of any mechanical deficit. And we want to make sure that that patient is giving themselves every mechanical advantage by running with a slightly wider gait. That if they have that crossover gait, there's a problem. And maybe more than problems at the knee or the hip, the feet support and the athletic shoe age is very crucial. That our athletic shoes tend to wear out after 300 to 500 miles. The shoes are still going to look good, so patients aren't going to want to get rid of the shoes that they just bought. But once they get to that point, it's time to get a new shoe so that there's adequate support and hopefully be able to stay running to the point of grandma. And our clinical pearls for this one, let's not forget, shin splints are not benign growing pains. They're a mechanical problem that is leading to a stress fracture. Once the pain starts to linger for a long period of time, we're very suspicious of a stress fracture. When it starts to shrink, we're suspicious of a stress fracture. That may need imaging. We're going to address foot hyperpronation, and if we have that patient hop on one leg, we're going to be suspicious of a stress fracture if they have discomfort. We also have an exam form like we did for the knee. We have an exam form for the foot and the ankle. It's set up in much the same way, that we have the area on the right side that's going to allow you to put the OPPQ or ST. We have the area on the center of the form that's going to allow you to perform the orthopedic test per diagnosis. So I'll give you the information to download these as well at the end of the presentation.